with thrombolysis compared to not getting thrombolysis, but it is not statistically significant because of the confidence interval crosses 1. So the way to interpret that is it trends toward reduction in mortality. But these are some of the numbers that the societies have cited in recommending thrombolysis. All right, what about the randomized controlled trials? This is a little bit older trial, 93. It assessed people with non-massive PE, and they either had, everybody got heparin, they either got TPA or not. It did result in a statistically significant improvement in RV function and pulmonary perfusion by echo and nuclear medicine or angiogram, but it did not show a difference in mortality. MAPIT-3, I mean, it's the same guy that published it, and that's why they called it MAPIT, but I mean, this is a totally different study. This is a prospective randomized controlled trial. Normal intensive PTE patients with RV dysfunction by echo or pulmonary hypertension by echo or cath or EKG findings of strength, which is a kind of a wide definition, but they got either TPA or not. Everybody got heparin. This was a composite endpoint of mortality or escalation of therapy. So there's the EVIL composite endpoints for you. And escalation of therapy included if they had shock or had to have pressors, basically. Rescue thrombolysis, which if I'm not mistaken, yeah, it'll show it. Or if they had CPR, emergency embolectomy, or catheter fragmentation, which is, you know, it is escalation of therapy, but anyway, I don't know whether that, how significant that ought to be in the endpoint, but it is what it is. So a quarter of the non-thrombolysis patients had escalation of therapy versus, or had the composite endpoint versus 11% of the of the control group who had it. But if you look at mortality, it was not statistically significantly different, and if anything was a little higher in the treated group. So most of the composite endpoint result was driven by the escalation of treatment. And when you look at where is it, secondary thrombolysis, almost a quarter of the patients who didn't get thrombolysis got thrombolysis. So again, makes it tough to interpret. And then so bleeding was a little bit higher actually in the non-treated group, but it didn't reach significance. Sort of funny is not the right word, but interesting, I guess, that the hemorrhagic stroke, there was only one and it occurred in the non-thrombolysis group. So who knows? Let's see, I think I got one more. Okay, so MOPIT, and there's also a MUPPET trial that looks at PE, and I didn't even read that one because MAPIT 1, 2, and 3, and then MOPIT, I've had all the mopping and mapping I could handle. But it's at 120 people. It's a randomized controlled trial. And they tested a, quote, safe dose of TPA, so half of the typical dose. The 100 milligram dose is what you give for acute coronary syndrome and ischemic stroke, I'm pretty sure. Y'all deal with that a lot more than I do. But you know, only 5% of the circulation goes to the coronaries and only 15% goes to the brain, but 100% goes to the lungs. So the thought was maybe with so much of the cardiac output going to the lungs, maybe less TPA would be effective. The lungs do appear to be pretty sensitive to thrombolysis. So that's what they thought. And then if you weigh less than 50 kilograms, they did it weight-based. They also had a reduced PTT goal. Most of the, you know, there's typically 2 heparin protocols at any given hospital, and that's based on society recommendations that for PE or VTE, you need a higher PTT than you do for coronary syndrome. But they used a 1.5 to 2 PTT goal, whereas most of the things we use are 2 to 3 times normal. So they use a reduced and then low molecular weight. Maybe it's 2.5. What is it? Maybe I'll keep my mouth shut. But low molecular weight heparin 80 BID, if you're up to 80 kilograms, is a full therapeutic dose. They did it weight based, but no more than 80 milligrams BID. And they had to have a moderate PTE, but it wasn't a physiologic definition. It just kind of makes you a little bit mad that, you know, or frustrated at least, that in this was a 2013 paper, they're still talking about, you know, this PE severity based on thrombus burden. Not that there's no, you know, merit to that at all, but I mean, it's a clinical issue. I mean, if people, it's been widely shown that RV dysfunction and or biomarkers being elevated and or pulmonary hypertension puts you at risk for a higher risk of death and poor outcome. So the fact that they're just basing it on thrombus burden is kind of upsetting. So I sent a letter to Dr. Sharifi and told him what I thought about it. Not really. But they excluded people that had a pressure less than 95, so none of these patients would have been considered massive PE. They measured the RV characteristics, but they weren't part of the inclusion criteria, and they didn't report the outcome related to the RV findings on echo, so kind of useless. They did look at pulmonary hypertension at 28 months. It was 57% in the control group, the just anticoagulated group, and 16% in the treatment group. And that was significant. 28 months is a pretty good long-term study for PE. Usually they're looking at 7 days, a month, that sort of thing. So we're talking, what's that, a little over 2 years. Total mortality was 5% in the control group and 1.6% in the thrombolysis group, but that did not reach significance. Interestingly, it's that 5% is lower than the 10 to 15% I told you at the beginning of the talk. Who knows if it's because critical care is better? I don't know why, and it may just be that the patients aren't quite as sick because we don't know exactly what their RV care, if they had RV dysfunction and so forth and so on. So maybe they're not as sick, maybe we're better doctors, maybe it's a combination of the two. And there were no bleeding complications in either group, which they chalked up to either the low dose TPA or possibly in combination with the less therapeutic anticoagulation. There you have it. The other thing that's worth looking at is they did measure PA pressures at baseline and then at intervals. And after the baseline, which was not statistically significantly different, at beginning even at 48 hours and then extending out to over 2 years, the PA pressures were lower in the treated patients than the non-treated patients. Pulmonary hypertension, I mean, it's not something you want, so even if it didn't necessarily make a difference in mortality, not having chronic pulmonary hypertension is probably a good thing, as long as you don't bleed to death from the thrombolysis. All right, so then one more randomized controlled trial. Actually, I got two more. So top coat, the next two trials, everybody talks about them by name when you talk about PE therapy, but they haven't been published yet, and they were both presented at American Heart Association meetings like back in March, and they still haven't been published. So if you look at this one, you got to dig through the internet and find a JPEG image of the abstract that was inside the the little program that you get at the meeting. But at least it's an abstract, so it's very difficult to talk about any specifics with it. But it does look like it was it was submassive PE patients, so they had to either have RV dysfunction or elevated troponin or BNP, and the pressures were all over 90. It was 83 patients, and I think it was terminated early. They wanted to enroll 100, and I think it was stopped because they had good outcomes. Not that it's something that I understand, because if you look at this is like the mother of all composite endpoints. 5-day survival to hospital discharge without shock. I don't even know what that means. 5-day survival. You either survive for 5 days or you survive to be discharged, but whatever that means. And then shock, intubation, major bleeding. That all makes sense. And then at 90 days, normal RV. You can walk 3 football fields, and you're not short of breath at rest, and you don't have a recurrent PE or DVT. So it's just like just like a casserole of variables there. And then they also looked at self-perception of wellness on these quality of life studies, and those were significantly different too, better for the people treated. And then for the primary outcome, it was a favorable outcome, so the more of it, the better. So it was 65% in the thrombolysis group and 40% in the control group. It's just an abstract, so who knows what aspects of that occurred. Was it all because the mortality was reduced? Was it all because everything was perfect except that the other people couldn't walk 6 minutes or whatever? I'm sure it's a combination of all the variables, but there's no way to know what role each one played in the overall results until the paper gets published. And then last randomized trial I'm going to talk about is called PYTHO, or I pronounce it PYTHO, I don't know how you say it. And it was also presented at the AHA meetings, and it's from the current year, obviously. They randomized 1,000 patients to either get tenecteplase or placebo. They were all normal intensive. They had to have RV dysfunction by echo or CT, and the way they would measure on CT is dilation of the right ventricle, and typically a ratio from the right ventricle to the left ventricle. And they also had to have an elevated troponin. Now, it's not a hugely elevated troponin. I think it's, again, it's just, lecture slides is all that they have at this study. It hadn't been published, but, typically it's like over 0.02 or 0.2, whatever the low end of normal is, that's their cutoff for considering an elevated troponin. So it just indicates, some myocardial necrosis, but, not necessarily a huge MI. The composite endpoint was death or hemodynamic collapse at 7 days. So that's a composite endpoint I can sort of live with. So no letter for Mr. Constantinides. So the composite outpoint occurred 5.6% of the time in the control group, 2.6% of the time in the thrombolysis group, for an odds ratio of 0.44. So over 50% reduction in either mortality or hemodynamic collapse. And it turns out, guess what? Most of it is driven by the difference in hemodynamic collapse. The mortality itself is not statistically different. But it's a 7-day outcome, so it's kind of a short thing, although most people with PE die. If they're going to die, most of them die in the first hours actually after the event. So here we have it again. 4.6% of the control group ended up getting thrombolysis, even though they didn't get the initial study dose of thrombolysis. And 4.6% isn't all that high, although when you're talking about mortalities of 2%, 5%, maybe 4% of patients getting treated differently makes a difference. Like if these patients all survived and they would have all died, then you're talking about 10%. Well, not 10%. It would go up to, what, 8% or so. The treatment effect was much more pronounced in patients less than 75 years old. So for patients less than 75, this odds ratio, instead of being 0.44, it's 0.33. And their stroke risk was much lower than it was in the overall group. It was only 1%. In patients over 75, looking at the primary endpoint, it was the odds ratio was like 0.6 or 0.7, but the confidence interval was across 1, so it's not significant. This is some copied stuff from their slides. So non-intracranial major bleeding was more common, and this is the treatment group side, was more common in the treatment group than the placebo group. And then if you look at all strokes by day 7, there was 10 times the risk in the hemorrhagic group. But again, we're not talking about 20% like the old study and what's quoted in the textbooks. These patients only had 2% risk of hemorrhagic stroke at 7 days. All-cause mortality, it was a little bit numerically higher in the control group, but didn't reach significance. And if you look at the causes for the mortality, most of the control group patients died from the PE, whether it's respiratory failure, recurrent PE, or shock, hemodynamic collapse. Whereas most of the treated patients died from bleeding or stroke. And I don't know if this was the hemorrhagic or the ischemic strokes. We'll wait for the publication for that. And then some, a bunch of people died from just other causes. I guess they got hit by a truck or something after they went home. So anyway, it's kind of a wash in terms of mortality, but it definitely seems to have a positive effect on hemodynamic collapse and shock and those sorts of things. This is where it's going to start looking weird because it's a different font than what I wrote it in. I got the brand new PowerPoint, so it uses all these weird fonts that nobody else has. So what about catheter-directed thrombolysis? So that initial trial I talked about here was the one where they just sat the catheter way behind the thrombus and gave TPA, and that's no different than giving it in a vein. So you wouldn't expect it to have a different outcome. Nowadays, when we give catheter-based lytics, we actually try to get the catheter into the clot, and then it's kind of like a sprinkler hose. It's got all these holes going down the side of it, and it leaches, medication out into the clot, so you're actually delivering to the clot. Whereas if you're just sitting in front of the clot, the problem is blood doesn't flow through a clot by definition. So it's, although it'll have effect, and it does have effect in the pulmonary arteries, most of the blood that has TPA in it is going somewhere else. So anyway, more recently, this ultrasound accelerated catheter thrombolysis called the ECOS catheter has been shown, not yet in randomized trials, but has been shown to have really a pretty significant effect on clot resolution, as well as RV function and some other outcomes like that, with very low risks of bleeding, and low doses, much lower doses of the lytic than certainly than 100 or even than 50. Usually they get somewhere between 10 to 20 milligrams of the agent. Let's see. So there has been performed now a randomized trial of the ECOS catheter for PE, for submassive PE. And there's a couple that are still recruiting patients and haven't been published yet. This is the same deal, it was presented at the American College of Cardiology, but hasn't yet been officially published. So this is based on the slides. But it's kind of nice because I can just copy their slides and put them in mine. I don't have to actually do any work. But anyway, this is the little machine that rolls around on the cart, and it's kind of big and bulky. And then there's a catheter. You put it in the clot, and then put the ultrasound thing in it, and it does ultrasound and administers the drug at the same time. This is apparently what fibrin looks like when you don't have an ultrasound waves going through it, and then this is what it looks like. The idea being, it kind of opens it up, loosens up the how compact the strands are and molecules are to allow the medicine to get in between those strands and hopefully have more of an effect or a quicker effect. I don't know what that other picture is. So they had 59 people that were randomized to either get it or not get it. They all had to have submassive PE. They all had to have pressures over 90, and they had to have this RV to LV ratio over 1 by echo. The thing about that is that it's something that apparently is somewhat easy and somewhat reproducible to check. You can also measure on a CT, I think, too, but all theirs were with echo. And it has been shown, it's been looked at in numerous trials, and it is very predictive of either mortality or bad outcome, however you want to look at it. But so is hypokinesis and elevated PA pressures and elevated troponins and some other things. But RV to LV ratio really appears to have a lot of prognostic value. So what this study is looking at is, as a primary endpoint, is the reduction in this ratio, RV to LV ratio, at 24 hours. And I'll tell you in a minute why they made it 24 hours. 80 and 77% of patients in this study had a positive troponin, which kind of goes along with, they were among the sick. So this is one of the ones I copied from their presentation. And so the RV-LV ratio, and these are the treated patients, the average was 1.28. So anything over 0.9 is considered significant. Certainly over 1 is. And then a little bit lower, but this was not a statistically significant difference, but a little bit lower in the patients that were not in the treatment group. And then you can see that at 24 hours, there's a pretty abrupt drop in the ratio, which is a good thing. And then for the untreated patients, or for untreated is not the right word, the control group patients, it had not reduced very much by 24 hours. At 90 days, they had both come to a fairly significant reduction, and I think that's why they made it 24 hours, because it wouldn't have shown what they wanted it to if they'd done it for 90 days. But when you look at the reduction, which is actually the primary endpoint, is the reduction. So the difference between here and here is significantly more than the difference between here and here. Even though this does show though that with anticoagulation, if you live, your PA pressures will probably go down on average over time. Although there are a lot of people out there with chronic thromboembolic pulmonary hypertension, and it's a bad problem. But if you look at baseline to 90 days, reduction is just barely statistically significant compared to the non-thrombolysis group. And I just can't even look at that. All right, so some other techniques are what we call pharmacomechanical thrombectomy. So pharmaco meaning, you're given a lytic generally, and then mechanical meaning, physically breaking up the clot or doing something to it. This is just a quick short slide on this, but catheter fragmentation, typically you get a pigtail catheter, which is the one with the circle on the end, and you put it into the clot and just kind of spin it around, and it'll break the point is that a lot of the problems from the PE, the hemodynamic problems, come from the fact that the heart is trying to push against this clot right here. And if you took the same amount of clot and distributed it way out in some of the smaller vessels, it might well, because the cross-sectional area in aggregate of all these arteries out here is much higher than the main PA, even though they're small on an individual basis. So if you break it up and get the clot to go out further in the lungs, that ought to reduce the load, the outflow load on the heart, and potentially improve hemodynamics and maybe even lung perfusion. At least it sure does in that picture. So the other thing is aspiration thrombectomy, which just means you suck the clot out, and you put a big catheter up there and just try to suck it out. There's